Okay? It's a pleasure to introduce you. You have a lot of paper about the disease, and we are happy to listen to you.
Thank you very much. And it is actually a great pleasure for me to present you my thoughts about this very fashionable topic, which is the deep endometriosis and pregnancy wish. And I will try to focus the challenging circumstances. So we have not to confound the surgery of deep endometriosis with the surgery of ovarian endometrioma. So performing a colorectal surgery in a patient with endometrioma does not mean that you have to do the cystectomy. You can just drain the ovaries, you can perform a sclerotherapy or a plasma surgery, plasma ablation, but not to perform the cystectomy. So the surgery of the cystectomy of ovarian endometrioma may decrease the ovarian reserve. The surgery of deep endometriosis, it is not sure at all. And myself, I stopped to perform the cystectomy in 2009. Now, if you have a look at the guidelines, you can see that all the guidelines say that we have no randomized trial, so we have no argument to propose the surgery prior to the IVF when the IVF is required. But as the guidelines say that this woman often suffers from pain requiring surgical treatment. So in my daily practice, I frequently see patients with deep endometriosis who had 1, 2, or 3 IVF and were considered not very painful. But what suffering from pain means? Most of IVF colleagues, or colleagues involved in ART, think about dysmenorrhea and chronic pelvic pain, and they say that this pain should be reduced by giving a pill. However, deep dyspareunia is frequently not considered to be a pain, because if the patient has no sexual intercourse, it is not painful. However, for me, the deep dyspareunia in a young woman requires a surgery, because young women should have sex. Now, dysuria. Dysuria is not painful at all. And I see every day, to every consultation, I see at least one patient with deep endometriosis who had some difficulties to void the bladder. For me, the dysuria is much more severe symptom than a pain, because it means that the splanchnic nerves are involved, or at least the lesion is very close to a splanchnic nerve, meaning that if you remove the nodule, you risk to have a postoperative bladder voiding problem. And here you see, it is in French, but it is a patient I managed last month. She had 3 IVF, and I asked her to perform urodynamic test, and the post-voiding residue volume was 300 milliliters. So she has self-catheterization prior to the surgery, not due to the surgery. Blotting. Blotting is not actually a pain. However, it's a very severe symptom in patients with colorectal endometriosis. And I am set up by the number of patients I manage every month or every 2 weeks, which have subocclusion due to huge lesion of the bowel, responsible for blotting, but nobody asked them before if they have blotting or not. So we reported 4 years ago a series of 12 patients, but now I stopped counting the patients with subocclusion and subocclusive symptoms, and most of them with IVF, because there is no pain. Silent kidney. Since March 2019, so during the last 7 months, we removed 5 kidneys with 0 residual functional function. So I was set up, and all these patients were under ART management. So the silent kidney is not painful. The patient may have a dilation of the ureter due to a big endometriosis, which is not very painful. However, they can lose their kidney. And I think it's if you perform the IVF, you should to check the kidney features by ultrasound, because it's a big problem for me. Then the sacral roots and sciatic pain is not a pain related to endometriosis for a majority of my colleagues or of our colleagues. So they send the patient to kinesiotherapy osteopathy, but the patient has a symptoms related to endometriosis. So this is also a pain. So all these symptoms should be considered in the terms patient suffering from pain. Now let's come to the patient coming to us to ask what she has to do because she has to be pregnant. She wants to be pregnant. She stopped the pill 6 months later, and due to pain, she had the diagnostic of colorectal endometriosis. And of course, we have to provide information that if she has first-line AOT, she may expect 43 or up to 68% of pregnancy if she has to undergo at least 3 IVF. This is the study of Ballester, so I don't speak more because both my colleague spoke about. If the patient has the surgery first, they may expect up to 80% of postoperative pregnancies, and I speak about my patients. This is the Endo randomized trial, which was a trial comparing the colorectal resection to excision, disc excision or shaving, in women with severe colorectal endometriosis. And the fertility was not the main outcome, so all the patients had first-line surgery. And then I continue to follow them up, and in 37 women who have attempted to get pregnant after the surgery, and 2/3 of them were infertile, known to be infertile before the surgery, we have 80% of pregnancies, and the majority of them spontaneous conceptions. And if you have a look at women who are considered to be infertile because they have attempted more than 1 year to get pregnant before the surgery, we have 74% of pregnancies and more than a half naturally. And this woman with colorectal endometriosis and 1 year infertility, in my opinion, a lot of our colleagues refer her directly to IVF because she's infertile and she has a deep endometriosis. Now, about the comparison of IVF and primary surgery, the study of Bianchi was mentioned by Michel. So the patient choose themselves to have IVF or surgery followed by IVF, but the study took into account only patients who had the IVF after the surgery. So I called Paolo Bianchi and I asked him to have a look at how many patients were naturally pregnancy in both arms. And he observed that in the arm of women who choose to have IVF, there were 9% of patients who had a natural pregnancy, which is logical because even in very severe endometriosis, there is a probability of 10% of pregnancies, natural pregnancies. While in the other arm, there were more than 20% of patients with spontaneous pregnancy. So this gives a difference 30% against 50%, so statistically significant. Now, what about the low ovarian reserve? The patient has a low ovarian reserve. So we asked ourselves these questions, and we reported a study where we had a look at the IVF, at the AMH before the surgery for severe endometriosis. And we compared the patients with normal AMH over 2, with slightly low AMH between 1 and 2, and low AMH below 1. Now, I want to emphasize that when the AMH is low, this is specifically the population where the IVF provides worse results. So I think that in these patients, it could be logical to fight to give them a chance to be naturally pregnant. And if you have a look at the pregnancy rate in women with less than 1 nanogram by milliliter AMH, you can see that 68% were pregnant, and again, 2/3 were pregnant spontaneously. So if you compare the three groups, you see that the lower the AMH, the higher the rate of spontaneous pregnancy. So I think it is not mandatory to send them an IVF, because if you perform the surgery, you can give them a chance of natural pregnancy. Now, complications risk. Of course, I'm about to submit a manuscript with 1,102 patients managed by for colorectal endometriosis in 3 departments in Rouen, in my present clinic in Bordeaux, and in a clinic in Rouen where I have a very good surgeon friend of me. And we recorded 3.4% of fistula. 3.4% is a low rate of fistula, and we should put it in balance with a high postoperative pregnancy rate, with a long-term improvement in pain and quality of life. And I've just published a paper in Human Reproduction where I followed up more than 5 years the patient enrolled in randomized trials, so the improvement is constant, and after 5 years, and with low rate of colorectal recurrences, 1.6% at 5 years. And also, we have to ask if you refer the patient for the IVF, it means that you postpone the surgery, as well as if you refer the patient for surgery, you postpone the IVF. But postponing the surgery, is it always safe? And this morning, my friend Antoine Netter presented our study where we observed that in women with several MRI but without surgery, meaning that a majority of them were trying to get pregnant for more than 3 years, in 40% of them there was the obvious growth of the nodule. So the cutoff was high. It means that in 40% of them, nobody can contest that the nodule increased. So there is a risk that the nodule increased. And so what? Like everything may change, because if a rectal nodule increased by 1 centimeter, maybe is the 1 centimeter too much to perform a conservative surgery. Maybe is the 1 centimeter which completely is responsible for the ureteral stenosis and the kidney loss. Maybe it's the 1 centimeter laterally close or where close to splanchnic nerves or involving the splanchnic nerves. And also postponing the surgery, it means to prolong the pain of these patients. But I think we have to give up some fake news, such as the surgery impairs the fertility. If you have surgery, you will never be pregnant. And I am sure that if we choose only one technique, it cannot be suitable for all the patients. So some patients need ART first, some patients need surgery first. In my opinion, maybe there is a bias in the patients I used to see every day, but in my opinion, there are more patients with deep endometriosis and pregnancy which require surgery than first-line IVF. And if you choose, let's say that we choose to perform an IVF, 1, 2, or 3, because we need 3 to get pregnant in 68% of cases. I think it is mandatory, if you choose the IVF, to do a complete deep endometriosis assessment, to discuss the case in a multidisciplinary meeting, including experienced surgeon in deep endometriosis, not surgeon who is not experienced that, it's too risky to manage, it cannot be managed surgically. Experienced surgeon. Also, if you choose to recommend IVF, don't forget to give a contraceptive pill continuously in order to avoid that the nodule grows. And if you want to do the IVF, my advice is don't push too far your luck with this choice. Thank you very much, and please. I'm very pleased to invite you in Shanghai for the World Endometriosis Congress, where our society, European Endometriosis League, will present a pre-conference course. And also, within 2 years, I will welcome you in Bordeaux for the 6th meeting of the European Endometriosis League.